So I'm going to talk about cancer survivorship, and I'm a researcher, so my background's in psychology, but I am a researcher rather than a clinician. So I'll tell you a bit about the research that's gone on in that sort of field. So firstly, I'll talk a bit about some background about survivorship. What are the issues for survivors, but also for the partners and caregivers of cancer survivors? And I'll just briefly describe to you a couple of interventions that we've got in place at the moment that we feel will be helpful to survivors. So just as a bit of background, you know this literature, I'm sure, but 1 in 2 men and 1 in 3 women will be diagnosed with cancer by the age of 85. Survivorship is actually getting much bigger. Cancer is being detected earlier. There are much better treatments. So almost 2/3 of adults and 3/4 of children who are diagnosed with cancer will actually live past the 5 years. So as you can see from that big arrow on the right there, the gap between being diagnosed and surviving is actually getting bigger and bigger, and we're getting more and more cancer survivors as a population. The prostate cancer stats, which again have sort of been mentioned a bit as we have gone on. So it's the most common cancer overall. The first cancer, the highest cancer that's diagnosed in men. 1 in 4 Australian men will be diagnosed by the age of 85, and the 5-year survival rates for prostate cancer are really very good, so 90% survival, which means there will be many survivors living for many years to come. Ovarian cancer, it's the 10th most common cancer in females. So the 5-year survival rate is less good, but that's largely because early detection is not as good as it can be. So, and I think Ian mentioned that earlier as well. So we did a survey some years ago now where we asked over 1,000 cancer survivors what they thought about cancer 2 years after their diagnosis. We really asked them about what's their appraisal of cancer. And you can see from the responses on the right there that for many people, you know, it was just a combination of part of living, positive, stressful. So it was a mix of things for people. But you can also see that almost 20% of people, so 1 in 5 people said 2 years after the diagnosis, it continues to dominate as a stressful event in their life. For 3% of people, they reported it to be a positive experience 2 years later. And that comes back to reassessing what are your priorities in life, etc., what's more important for you now that you've had this experience and so on. So it was important for us to understand what people were feeling about their cancer 2 years after the diagnosis. Some of the issues facing survivors, we know that as a whole, survivors have inferior health to the general population. And they experience a range of not only physical sorts of issues, but also psychosocial and practical challenges. And those are some of the things that they may experience that are listed up there. So risk of recurrence, risk of second malignancies, various toxicities after their cancer treatment, uncertainties and psychological issues, which again have been mentioned by a number of people. Various sorts of lifestyle issues, which Rob alluded to as well, and various psychological and practical difficulties. There are issues about returning back to work, where you are now, what you think about your cancer, how it impacts your life, and so on. So the impact of cancer for survivors spreads across a whole range of different issues. And again, I won't go through them, but there are a lot of known effects, late effects of cancer treatment now that people are facing when they reach that survivorship stage after treatment or some years later for many people. Some of the physical challenges, there are short-term declines in the overall quality of life, but largely for most of the people they return back to baseline or population levels, so the general public sort of levels, between 6 months to a year after diagnosis. So that's a good news story. Not everybody reports low quality of life. and most people return to normal or something like normal. But unfortunately, that's not the case for everyone. So again, in the research that we've done where we've reported on quality of life longitudinally, so following the same people of time over a 5-year period, again, just looking at the 2-year data there, you can see that 1 in 5 survivors, which is the green pie there, report a quality of life that's actually worsened 2 years after diagnosis compared to what it was at 6 months post-diagnosis. So their quality of life has actually deteriorated over time. The blue bit of the pie there suggests that there's no change, so whatever they had at 6 months, they reported not changing so much at 2 years. And for 25% of people, so a quarter of people report an improvement in their quality of life. Some of the physical challenges that people face in prostate cancer. So for sexual, urinary and bowel function, there are severe and persistent side effects depending on what type of treatment people had, what age they are and what their baseline function was in those particular issues. Now this is a really busy graph, but what I wanted to show you really was, again, this is the survey that we did with over 1,000 cancer survivors, and we looked at the top 8 cancer incidents. So that's the list of types of survivors that we had in our group. And you can see that at 2 years post-diagnosis, so this is 2 years after they've been diagnosed, this is the quality of life mean score in terms of physical symptoms. So the higher the score, the more burdensome the symptoms are. And I can show you prostate cancer here, but we didn't have ovarian cancer survivors in our sample. But basically the dark blue bar, you can see that for many people, fatigue continues to be a significant problem at 2 years post-diagnosis. Probably the other one that stands out is insomnia. So this is people reporting that they have significant problems with these particular physical symptoms at 2 years post-diagnosis. Some of the emotional challenges that people face, so approximately 10% of men with prostate cancer report high ongoing psychological distress. And we know from our research as well as published research, and some of this is Suzanne Chambers' research, that partners' distress is often higher than the patients themselves. Now, can I just get a show of hand of who are partners or caregivers in the audience? Okay, so it's great to see you here. Some of the other issues, and I can't remember which of the speakers, someone, I think Rob mentioned low masculine self-esteem. It seems to drive male patient distress. And the other side of all of that is that the man's distress seems to drive the female partner's distress. So it ends up being a cycle of distress that we really need to be able to pick up on and offer help in a timely manner. Between a third and a half of men with prostate cancer have high levels of unmet need in a range of areas for psychological help, but also information and support needs relating to sexual function and bother. And again, Rob mentioned that in his talk. Some groups do less well than others. For example, men who are younger at the time of diagnosis report higher unmet needs and higher distress. And men who have low levels of education tend to have more difficulty accessing and then applying support to their situation. So there are some flags there where we, as health professionals might say, this group of people looks to be at higher risk. We need to particularly keep an eye on them and see what additional support we might be able to offer, for example. So now on to the partners and caregivers, and I'm really only giving you snippets of some of the research that's out there. But for partners and caregivers, they're often expected to take on additional roles when their partner is diagnosed with cancer. They provide emotional support, practical support. They may have to engage in illness self-management and do tasks that, really they haven't been trained to do. Some of these challenges can become quite burdensome, and may exceed the capabilities of the partner or caregiver, leaving them feeling quite burdened. We know that partners are at increased risk of a range of different things, such as poor quality of life, social isolation. For example, if the partner or caregiver has had to reduce their work, for example, that might be the place where they have a lot of interaction with other people, etc. So that's affected. Financial strain, again, cost of treatments, but also potentially having to either reduce or give up work to look after the person with cancer. Physical health risks. We know with cancer, people generally are diagnosed at a later age. Hence, the partner or caregiver is often of that older age as well, and they have their own physical health problems to deal with. Being a caregiver exacerbates some of those. And also they're at higher risks of high levels of anxiety and depression. Now, I wanted to put this up because this is, the range of anxiety reported in the literature for patients is 10 to 50%. And you can see that the partners is about the same or even slightly higher. And also the same sorts of comparisons with depression. So the partner or caregiver of the person with cancer is at least as affected in terms of anxiety and depression as the patient themselves, and our research suggests that anxiety is even higher for the caregiver than for the patient themselves. And that comes back to, I think, some of the, actually just to comment on that, in a lot of our surveys we ask patients, have you accessed the support of a psychologist or a support group or other sorts, cancer helpline, for example, other sorts of support like that. And often they say, no, I haven't, because I've got enough support at home. But what we're seeing here is that the support they're getting at home, the partner is actually being impacted by that. They're perhaps holding it in, giving support, but not getting the support they need to help them through the experience. When we look at, we've done quite a lot of research asking people about their levels of unmet need in a range of areas, physical issues, psychological, financial, etc. When we ask partners and caregivers about their unmet needs, quite early in the post-diagnosis phase and for some time afterwards, they're really focused on trying to help the patient, for example, reducing the stress in the person with cancer's life, or managing the fear of recurrence, for example. So they're really focused on the issues around the patient themselves. The needs focused on themselves as a caregiver become more important with time. And what we found is 2 years after diagnosis, up to 1 in 10 caregivers report having a moderate or a high unmet need. So this is a need I have which hasn't been met by the system, in things like dealing with others not acknowledging the impact on your life of caring for a person with cancer, the impact of cancer on your relationship with that person, and looking after your own health. So at 2 years post-diagnosis, they're starting to think about, okay, well, what's the impact on me of this caring role that I've taken? So I guess one of the things is we could leave people to their own devices, and many people survive well enough on their own without any assistance. But really, we need to be it's really important for us to stay focused on what we can do to help people through that cancer experience. And I'm really just going to mention 2 particular interventions that we are working on at the moment that we think are quite helpful for people. One of them is called Coping Together, and it's a coping intervention, and I would like to acknowledge Sylvie Lambert and Janelle Levesque, who are in my team, who are doing a lot of work on this particular project, which is funded by the National Health and Medical Research Council. It's essentially a multimedia, self-directed coping skills intervention for couples who are affected by cancer. And we're recruiting people who have prostate cancer, bowel cancer, breast cancer and melanoma. So they're the 4 groups that are part of this particular trial. the core components of the intervention. So it's very much about self-management, empowering people to work on strategies to help themselves as a couple to better face cancer. So the core components are 6 booklets, and that's the cover of one of the booklets. A DVD, because again, the pilot studies that we did when we were developing this intervention, people said, look, the booklets are fantastic, but when I really, excuse my French, feel like shit, I can't sit and read through this booklet, but I'd watch a video. So we thought, okay, well, we'll put it on a DVD and people can just put that in and look at that when they're really not feeling very well. And there's also a website. And the purpose of this is to collate all of the information that we can find about the up-to-date research on effective and practical coping strategies, and presenting these to couples as suggestions for how they might address, specific psychosocial and physical issues. The booklets that we have cover those 6 topics, which were identified from people that we interviewed, being, some of the big challenges that people are facing after they're diagnosed with cancer. So symptom management, managing worries and emotions, supporting each other, getting what you need from the healthcare team, which is really about effective communication, how to make treatment decisions, so thinking about decision making, and considering your support options. So this study is in the trial phase at the moment, where we've started recruiting people. It's a 4-year trial, so the results are a little way away yet, but we have found from the pilot testing that people really love the resources, and we hope that they will be really useful when we trial them. And they can be, the important thing is the translation of evidence into practice. These are resources which could become available to people, for example, through PCFA, through the Ovarian Cancer Australia, through the Cancer Council, through their Cancer Treatment Centre. And it overcomes the issues of geography. People living in rural areas can't get to see a psychologist, for example. It empowers people. So it's a watch this space. The second one I wanted to talk about is really based on the rationale that we really have to be thinking about innovative models of survivorship care. Because while people absolutely adore their oncologists, and they do from the surveys that we've done, the oncologist is the person that they want to keep going back to. The oncologist-led follow-up may not be the optimal kind of way to be addressing many of the survivorship issues. For example, there may be limited attention given to supportive care or rehabilitation, for example. Is the oncologist the best person for you to see if you've got osteoporosis or if you've got lymphedema, for example? Or is someone else more likely to be able to address that issue in a timely way for you? There is the potential for excess medical reviews and testing. And the important thing is that the survivor population will definitely outgrow the oncology workforce population, and there will come a point when it's going to be quite difficult to sustain that model. We're probably nearly there now. The other issue is that people living outside, major metropolitan cities in Australia have very limited access to medical follow-up care. And particularly things like lifestyle programs or psychosocial support. And that's a message we get, repeatedly from people living in rural areas, for example, where those sorts of services are quite limited. So we need to be thinking about how do we reach those people in an effective way. So we really need to think about innovative models to meet the needs of the growing population of cancer survivors, and thinking about, either e-health models, which are remote, or shared care models where the GP becomes much more engaged in the care of the survivors in the long-term survivorship sort of area. So one of the really exciting initiatives we've got going on in the Southwest Sydney local health district is we're moving towards an e-health model where, from the time of diagnosis to long-term extended survivorship or end of life, so basically from the time of diagnosis on, We want people to be engaged in an eHealth online system which identifies what the issues of concern are and what's the most appropriate care pathway that's relevant for that person depending on what their issues are. So needs-based care across the cancer continuum. And the key components of that particular eHealth model is that there is routine and periodic assessment of things like unmet needs, distress, quality of life, symptoms, etc. in the clinic when you're having treatment, but when you've finished treatment and you're at home, you get a prompt to complete the particular surveys from home. Using smartphones, using your computer, using the web, etc. So we're going to be developing a number of different models for you to be able to input that data. You know, for say men with prostate cancer, you can put in your PSA levels, for example, or you can put in the physical activity over time so that that information is being used to either prompt you to be doing more of something or to go back and see your doctor about something. Or to give you information. So the second part of it is really using that information that you input into the program to then tailor the type of care that you receive, whether it be self-management, because a lot of people want to do things to help themselves, or shared care with the healthcare system. You can access information or resources, you can be participating in webinars, receiving online support, etc. Or it could prompt you for a referral if you hit a trigger point that suggests, for example, you've got very high levels of anxiety and you might benefit from talking to someone about it. So that's the second key component. And the third key component is really to focus on promoting shared care with the GPs. GPs want to be involved in cancer care, but currently their main issue is that the communication between the cancer centres and the GP about patients is less than optimal and it's not very timely. And that's, you know, evidence that we've got from research that we've done quite recently. And we're at the moment thinking about how do we ensure that communication is better so that there's a continuity of care when you go back to your GP. So I guess the message I want to leave you with is that we know that optimal survivorship care involves many key players, which isn't just the specialists, it's also GPs. Survivorship clinics are something that's being talked about and set up in a number of places now. There's a range of community services, and you know, if we start thinking about some of the support you might access, there's a lot of community services that could be accessed. Non-government organisations such as cancer councils, for example, PCFA, other groups. And there's also the self-directed care. Many people are saying, I want to get the information to be able to help myself. I want to take some charge here. And really thinking about how do we focus on empowering survivors and partners and their caregivers in the way that they would like. How do we promote self-care, and also how do we efficiently use the scant resources that are out there at the moment to ensure that people that need them most are the ones that are getting them. Thank you. Oh, look, I probably thought of support groups in terms of somewhere in there, but yeah, look, I'd see them as part of NGOs and community services and so on. Yeah, I will edit my slide for the next talk. I will do that, but I wasn't leaving them off intentionally. I saw them as quite critical in there. Thank you for the comment. I don't know about single people specifically, but I know social support is a huge factor in how well people do. So in a lot of studies, social support is a significant predictor of how well people do. So whether it's social support they receive from a partner or a friend or a network around them isn't necessarily specified, but that is an important factor. But Kate, do you know of any, I don't know of any specific research.
Or they are alone,
Yeah.
the psychological outcomes are worse.
Yeah.
So it's not,
Yeah.
you can have a partner, but it's not the
Yeah.
good partner.
Yeah. Yeah.
Is there anybody here who can add to that, who may know of a single sufferer or be one, or yep?
Well, just to say, from a PCFA point of view, we do hear anecdotally that single people going through a prostate cancer journey do experience different issues, and some of those issues are much more intense. So it's an area of interest for us, and we're really putting some work into that going forward. It's not dissimilar actually. Where it's come up for us is we've been doing quite a lot of work over the last 18 months or so with the gay and bisexual community in prostate cancer, and their experiences, and because of the different nature of some of those relationships, and it's actually come up as part of that work as an issue. So we will certainly be investing some time and effort into it going forward.
And I think too, some of the issues perhaps for single people, depending on, you know, where they're at with their life, etc., is about getting back into a relationship. So, you know, some of those survivorship issues, I suppose. So how do you tell someone that you're just getting together with that you've had cancer, and you might have a whole lot of issues that you're facing at the moment, whether they be physical or psychosocial or whatever. So there's all the anxieties associated with that as well. Disabilities is another one that people have raised with me about whether there's particular work done in survivors who have disabilities.
Are single people less likely to put their hands up for support, do you think, than... I'm not asking you specifically, but yeah, you're nodding?
Yeah. I mean, I'm going through cancer and single, and you have a whole raft of issues of not only just the dealing with the cancer, but for dealing now with the loss of fertility and grieving all of that alone, and not having someone to share those sorts of things with. Having older parents, you don't want to burden them with it, and you do get to a point where even the friends and things around you, they're all generally married and they have their other priorities too, and you do start to feel very isolated in a lot of the different parts, not just the dealing with the getting to and from hospital for treatments and things like that, but all the other side effects of having cancer, basically the psychological.
So can I ask you a question, because this is really an important issue, because the research really does show strongly that social support is an important factor, and I wonder if you have any ideas, you know, for us researchers about what kind of support you would find helpful in that sort of scenario. And I don't want to put you on the spot, but there's my email, so if you want to email me afterwards, that would be great. But yeah, that kind of...
Can I say on that, I think that's a function as much of age as being single, because I too am a single woman in her 30s, and it's quite different. I mean, and support groups, there's not much use me going to a support group with a 70-year-old woman with ovarian cancer.
Yeah.
Her issues are enormous for her, but they're very different to my issues. So you do need to...
Can I just make a comment?
Yeah, then we go up to you.
I think it's important for people to understand that support in the support group sense is not turning up. It's getting in touch with an organisation that has got a support group network. In many of our support work in the network, we're talking to people on the phone. We're meeting them and having coffee with them. And one of the most important things about a support group network is we can put you in touch with people that are a similar age going through a similar situation. So it's more a linking into the network that's the important thing to remember.
Yep.
Can I just say further to this discussion, my personal feelings is irrespective of what cancer you have, what gender you are, what your marital status, your age, I haven't had support to an access group because I don't live in Sydney. And I think we should be embracing as people suffering this together. No matter what our genetic, we should be helping each other. It doesn't matter if we're 30, 70, we're men, women. And I just recently had an incident where I was invited to attend a support group for breast cancer sufferers and was told that I wasn't one.
Oh dear.
And I was mortified, and whatever time I have left, I'm going to change that.
Absolutely.
Number of young women affected by ovarian cancer who we've had individual connections with, and there were 2 that were at the session last week, as there are a number today as well. So women diagnosed in their 20s and early 30s who want to connect with other young women. And in ovarian cancer we have some of those challenges about numbers, and you can't have a young women's support group everywhere because there's not enough young women, etc. But we've got a monthly tele support group, and I think we'll schedule one soon that will be a young women's tele support group for perhaps just an initial discussion where women who are diagnosed young with ovarian cancer can actually get on the phone and talk to each other and start a conversation about that. And we can also have a conversation with you to hear about how we could better support you. But that's a really simple and easy way of us. Maybe we can start with a phone conversation where we get people together. So let's, you've got my word on that. We'll do that again next month.
We probably have 5 single people in our group, varying in age, whether they're widowers or never married. But they are very enthusiastic participants in our group, and I don't think they feel isolated in any way with that. If that's what I was following the drift of there before.
I think one of the key messages is one size isn't going to fit all with any type of support for people, and we really need to ensure that people know about what types of support are available so they can access it, whether it be online or physically going to a support group or having telephone support, for example. There's a whole range of different options, but I think the key message is making sure that people are told about those and they're informed in a timely way so they can access that information and not feel like they have to find it all for themselves as well.